Yes. السلام عليكم ورحمة الله. وكل عام وانتم بخير ان شاء الله باجازة سعيدة. Happy week and welcome back. My name is Dr. Nader Khair. I'm a consultant endocrinologist, American board in internal medicine, American board in endocrinology, and I have an American board also in thyroid and ultrasound of the human. Currently, I work in Dr. Sulaiman Al Hariri Hospital, Aswadi branch. This lecture is going to be about thyroid, followed by another lecture about the parathyroid gland, and then we have the discussion about the thyroid and parathyroid. So total of 3 lectures. After those 3 lectures, I bet you will be able to understand the clinical manifestation of thyroid disorders and how to order the test to lead you to the diagnosis and the treatment of the thyroid and parathyroid disorders. Next week, inshallah, we'll start the diabetes, type 1, type 2 diabetes, and other subtypes of diabetes, clinical manifestations, treatment, and complications, and also the approach to the patient with diabetes. So you will have a total 6 lectures with me. Feel free. I'll give you my email and also my phone number. If you have any question or anything that you don't understand during the lectures and we don't have the time, you can always feel free to email me, text me, WhatsApp me, no problem, okay? I'll be writing few exam questions also. I will discuss some of the questions during those lectures. It's all about the concept. The first concept in endocrine in general is the feedback mechanism. Everybody knows about the negative feedback mechanism and positive feedback mechanism of the endocrine glands, right? This is how we test for the thyroid, and we understand how the thyroid function is by knowing the negative feedback of the thyroid gland. So today's lecture is an introduction about the thyroid function test. I'm sure that you have discussed this in anatomy and physiology about how the thyroid works and where it is located. One of the big problems that we see in the clinical, because my way is to make you a clinician, so my discussion will be like a clinical approach. So the first thing that we have problems in the clinical setting is people coming to us thinking they have thyroid problem when they have lymph node problem. The term for the thyroid or for the glands in Arabic, غدة الدرقية. They come to say that they have غدة. They point usually to this area here. This area here is where the lymph nodes are. And unfortunately, in Arabic, they call it glands, call it غدد. They come to you because of غدد, but it's actually lymph node enlargement, unless it is situated right above the clavicle right here. The structure, the thyroid gland, is a butterfly shape gland sitting just above the clavicle, not below the jaw. It's way down. And this gland is supposed to make what? To make the thyroxine hormone. Thyroxine hormone is just like the gas for your car. It's needed for your energy, for metabolism, for growth, for all the activities of every cell in the body from head and toe. All depends on the thyroxine for their growth, for their function. The main hormone that's the thyroid produce is the T4. And we know that why we call it T4? T stands for tyrosine, which is amino acid, the main one, and the four are iodine. When is the 4 is an active form of thyroid hormones, T4, T3. By losing one iodine, become the T3, the active form. Any other hormones besides the T4 and T3 the thyroid makes? Calcitonin. And that's do what? Calcitonin works in calcium. Okay, calcitonin is totally separate. And why is it sitting there in the thyroid? Parafollicular cells, right? It's a parafollicular cells. And those parafollicular cells, are they, the origin, is it the same like the thyroid gland, the other tissues? Where it is originated in the embryology? It's similar to the GI. So some people think it's migrated, supposed to go down to the GI, but stop way up in the thyroid glands. That's why it's foreigner to the thyroid tissue, the calcitonin. So it has nothing to do with the thyroid. The T4, I mean T4 and T3, nothing to do. So if you want to examine somebody with medullary thyroid cancer, you check for the calcitonin in the blood. You check for thyroid cancer, follicular or papillary, you check for the thyroxine and thyroglobulin. It's totally different. When people talk about thyroid, patients and doctors, most of the time they're talking about the thyroxine. 99% of the cases you will be encountering in real life and exam will be about the thyroxine abnormality. And you can see here when we say that how the thyroid function, we basically talk about the 99% of the time is the thyroxine, how it's produced. And you can see the positive and negative feedback. Thyroid, like other glands, when it is affected, we call it a primary or secondary disease. So the most common problem of the thyroid gland is affecting its function to produce the thyroxine or making too much thyroxine. And this is what? This is a primary problem. But if the problem coming from the pituitary, this is secondary. It's coming from the hypothalamus, tertiary, in that sequence. The most common one that's found in or encountered in clinical practice, primary. And primary, the most common cause for primary problems of the thyroid, antibodies, O2 antibodies. Okay, it used to be back in the days in the 80s and 90s, iodine deficiency. But the world finally get rid of this iodine deficiency by iodinizing the salts and rice in South Asia and like other countries. So back to the major thyroid hormones, T4 ratio to T3, 15:1. You see that? If you draw somebody blood, we can see that the ratio is T4 to T3 is 15 times. The thyroid gland makes T4 most of the time. It does not make T3 as much as T4. And why is that? Longer half-life, and it stays in the blood where it's usually bound. Most of this T4 is bound to thyroid binding globulin, TBG. specific made by the liver. But there are also other proteins, that's a thyroid, and other hormones combined too, which are albumin and pre-albumin. Those particles, they become like both ships for the thyroid, for the T4 to go to the site of action, to go intracellular, and then they do their actions in the intracellular, especially in the brain, through the enzyme, divide the T4 to T3, which is the main functioning thyroxine, the T3. What control the production of T3 and T4? So if we don't have TSH, if we don't have pituitary, can the thyroid work? No. Somebody can say yes?
Yes. There's like grapes.
No.
That's a topic.
Ectopic, if there is autonomous production of the thyroid, can work autonomous, but that's unusual. Usually disease like autoantibodies, yeah, the TSI, thyroid stimulating immunoglobulins, or thyroid receptor blocker antibodies, those are antibodies that can stimulate the thyroid to function, to produce something, right? While the TSH at that time will go home. When you test for the TSH, you'll see in those patients, the TSH goes down. So the thyroid can work this way. Can be ectopic. And if someone has no thyroid, what's the treatment? Levothyroxine. And that's levothyroxine will be what in the blood when we test? Will be T4. So when you test T4, basically you are testing levothyroxine, right? So T4, T3, TSH. The relationship, if we have too much T4 and T3, we'll have low TSH. And if we have high TSH, by default, this is what? If we have high TSH, the 99% if you have TSH, the problem is where? 99%. If you have high TSH, where is the problem? The thyroid. The thyroid. Primary thyroid disorder is superior to secondary in that order. So if you have to guess, and you are out of time, and you have to answer. If you see TSH, high TSH, thyroid has a problem. Huh? No. So I meant TSH is high. If you see a TSH is high, you start with the TSH. You see T3, T4, and TSH in the result. Don't look at the T3 and T4. Look at the TSH first, and then when you see TSH is high, usually it is problem of the thyroid, 99%. But it could be pituitary, right? Could be secondary, could be tertiary. So you put that in the back burner. You always try to think of the most common thing. If you see the TSH is low, again, this is a thyroid problem. Always look for the thyroid problem. But it could be secondary. It's low because there's low TSH coming. Okay? But that's usually rare, and that's a different workup and different clinical presentation. Always look at the TSH. Always check if you have a question. What's the next step in any thyroid problem? Even if the patient has a thyroid nodule, the next step is always TSH. This slide will show the difference between thyroxine, T4, T3, and reverse T3. Can somebody recognize the difference between those three formula? The iodine, right? Number one, the one in the top, we have 4 iodine. In the T4, T3 have 3. Then missing, see that the area that's missing the iodine give you the reverse T3. Anybody knows about the reverse T3? Is an inactive form of T3. So the T3, instead of the T4 losing one iodine in a specific area, it loses it in a different place. Okay, and that gives you reverse T3, and that's usually when the thyroid is sick, and the patient is sick, like in the ICU patient. Try to some people think this is a good thing for the body, a helpful thing. That's when you are very sick, you need to decrease your metabolism. So the thyroid still produces the T4, but when it goes to T3, it does not produce the active form, but give you the inactive form, just to protect your heart, to decrease the metabolism during time of sickness. And we call that sick euthyroid or normal thyroid syndrome. This slide here show you the difference between different 4 presentations of the TSH. You always look at the TSH. Number 1, the condition here says normal. Why is it normal? Because TSH is normal and T4 is normal, right? What happened here? The T4 was normal because the thyroid gland itself is normal. So sending a normal T4 to the TSH, to the pituitary, so pituitary will release a normal TSH. But number 2, if the thyroid producing too much thyroid hormone, then you don't need the TSH. TSH goes down, and this is in hyperthyroidism. Number 3, you see that there is low T4. If you have low T4, you have a positive feedback to the pituitary. Pituitary makes TSH, and TSH will be high. And number 4 example here, if you see low T4 and low TSH, most likely this is a secondary hypothyroidism. This clear? This is a basic. Then we will have, like, as we go in the lecture, we'll see different types, but this is the main 4 examples of abnormality in the thyroid function test: T4 and TSH. You first look at the TSH, and then you decide where the problem is. Thyroid function test. These tests are in the blood, right? Tell us about the thyroid function. Is any test that we can do not in the blood that tell us about the thyroid function? Somebody say CT scan can give us information about the thyroid. Thyroid what? Thyroid structure, right? In the CT scan. But function, I'm talking about function. Is sonography? Yes. Thyroid uptake. Iodine. And the iodine is a very good test. Why? Because it gives us information about the function and the structure, right? It can tell you about the nodule, is existed or not, multinodular goiter. Different types of nodules can be seen in the thyroid uptake, but also can give you if the thyroid is hyperfunction or underfunction. The very important thing, we don't order thyroid uptake unless we're thinking of hyperthyroidism. Cases of low TSH and high T4 and high T3, then you order thyroid uptake. And that's the only exception that we do something not in the blood for thyroid function test. Otherwise, for the function test, we do blood test. Mainly, screening for any thyroid disorder is the TSH. And then the T4 followed by T3. Do we order the T4 and T3 free or total? And what is the difference?
total is also the one bound to thyroid function. Yeah, the ones, but it's not enough. And 3 is the one that's not bound to 3.
Did you read that in the back? What's the difference between total and free?
Total is bound plus 3.
Total is bound, free is free. Right? Free is active. When it's bound, that means it's hugged by the protein, it's not easy to be released. It's inactive. So if I want to see how active is the thyroid, I will get the free. But sometimes I will get also the total. If it is, I cannot, in my lab, I cannot trust that lab for the free because the testing for the free is difficult because it's very small amounts. So sometimes they don't get it correct. And for that reason, we don't order free T4 in cases of hypothyroid because it's already low. We are satisfied by the TSH enough. TSH in hypothyroid is enough. But in hyperthyroidism, TSH is not enough. I want to see the T4 and T3 and always order free T3 and free T4 in those cases. When do we need thyroid autoantibodies? Here, guys. When do we order antibodies? Hashimoto thyroiditis is 1. Graves is 2. Just make it in general. We order those autoimmune disorder when we're thinking of them. But if somebody coming from iodine deficiency state, I'm not going to order them. If a patient have family history, why should I order antibodies? If a woman come to my clinic with high TSH, clinical picture of hypothyroidism, do I need to confirm it with thyroid antibodies? And she has family history?
No.
What is negative? If it is negative, does it gonna change my plan? If a test does not change your plan, don't order it. Most probably, it's the wrong answer. It's put in the answer choice just for distraction. There is a better answer on those 5 options than that. It's good. You can order it. It's just an addition. But it's not going to change the plan. Always, for the best answer questions, always pick the one that's going to change the plan, change the management.
Why don't you test for like if you suspect hypothyroidism? Why can't you use the iodine?
Because it's going to be low uptake anyway. We don't.
Confirm?
No. Because I can confirm, because it does not add, if it's, let's say it was negative, it was normal uptake. It's not going to add to my, hypothyroidism. And this is a very good question because hypothyroidism can be managed by almost all the physicians, family medicine, primary care, but hyperthyroidism is one that's complicated. And you see, it's complicated because of the physiology is different, pathology is different, the treatment is different, and part of this workup is the thyroid uptake. Hypothyroidism, we don't do thyroid uptake. And thyroid uptake, do you know how it's done, thyroid uptake, and why we do thyroid uptake? We give a radioactive iodine, assuming the thyroid is hyperfunctioning and love this, and we'll take it. But if it is hypothyroid, it's sleeping already. It's not going to take it. And those patients, when we send them to the lab or to the radiology suite to do this thyroid uptake, we tell them don't eat seafood or fish because it will affect the radioactive iodine. It will compete. Those iodine will compete. What other tests that can have loaded with iodine? Any test, CT scan with iodine contrast. Those also compete with the radioactive iodine. So we ask the patient not to take any radioactive, any contrast or any seafood for 2 weeks before the test. Yes.
If the patient has primary hyperthyroidism with family history of autoimmune disease, which is not take for all their body.
Because it's not going to change the plan. Why would you do it? It's good. It's good to confirm it. The patient asks for it, but it's not going to change. Like if you think the patient is already, you're talking about hypothyroidism, right?
Hyper.
No, for hyper, you need to do it because hyperthyroidism, we see it in the other lecture, they have a differential diagnosis of 3 or almost 4. The fourth we don't usually see is factitious, like somebody's taking outside thyroid hormone, let's leave it. But the main 3 for hyperthyroidism, Graves' disease, toxic nodule or multinodular goiter, and thyroiditis. And the way to differentiate between those 3, as we'll see in the next third lecture, that's by doing antibodies, doing ultrasound, and doing thyroid uptake and scan. But for hypothyroidism, if patient have thinking of Hashimoto, usually we don't have family history, you don't need to do the antibodies. Antibodies, we save it for the hyperthyroid in order to differentiate, because Graves' disease have positive antibodies, but thyroiditis and toxic nodules usually don't.
Let's say we treat the patient for hypothyroidism and
Hypo?
yeah, but then the treatment does not work. Do we then do the antibody? Or do
No. We increase the dose. Yeah. Thyroid protein, thyroglobulin. When do we test for thyroglobulin? Patient with hypothyroid, hyperthyroid, or thyroid cancer? Only thyroid cancer. We don't check it for hypothyroid or hyperthyroid. Does not add any value. And that's the reason. No value for hypo or hyper. We do it for thyroid cancer. When we do it for thyroid cancer? After treatment, to make sure that the thyroid gland, especially for total thyroidectomy, followed by radioactive iodine ablation, you want to make sure the thyroid is not producing any thyroid hormone, and there is no remaining thyroid tissue. Then you do thyroglobulin to make sure that there is nothing in the blood. What are the indications for thyroid function tests? As we said, you're suspecting hyperthyroidism or hypothyroidism. And sometimes you do it to monitor for thyroid suppression for patient thyroid cancer. And we do it for patients on levothyroxine for monitoring. We have to check for the thyroid function test. Other tests, as we said, and in my practice, I have never done the TRH stimulation test, but still, if you're thinking of secondary hypothyroidism and you think this is a problem of pituitary, you can give something TRH stimulation and to make sure that the T4 and T3 will go up. The same test we do the ACTH stimulation test for the adrenal gland. Thyroid uptake and scan for hyperthyroidism, ultrasound for thyroid nodules, thyroid biopsy, we save it for cold nodules, for nodules that's suspicious for cancer. There is a relationship between the free T4 and TSH, and you see that there is logarithmic relationship between the 2 of them. Any minimal change in T4 will give us high change in TSH. That's why we trust the TSH more than the T4, and the half-life of T4 is 3 to 5 days, and the TSH usually make changes within 2 to 4 weeks. So we trust the TSH more than the T4 for that reason. Let's give you information about the normal range for the TSH. Normal for general population, but depending on the population that's in front of you, like if the patient is female, reproductive age, the normal usually depends, is usually in the middle, not like 5, usually 3. And if he's pregnant, the first trimester is less than 2.5. And the second and third trimester, less than 3. So you have to know the normal range is for general population, but there is specific population, they have their own normal range. Then, as I said, TSH is 99% of the time will give you the answer, but some cases you need to order more tests beyond the TSH, especially if you're suspecting central, which secondary hypothyroidism is the most significant condition in which an incorrect diagnosis of euthyroidism, that you make the EU means normal, could be made based on TSH alone. If so, you have to be careful to add T4 and T3 in those patients. And other type of patient non-compliance with replacement therapy. Also, you might need to do 3T4. Early stage of therapy, during the first 6 weeks, the TSH might not be a good indicator of the patient taking the thyroid hormones. So you check also 3T4. And also in acutely ill patients, try to avoid ordering TSH because it's going to be low or normal. And the 3T4 and T3 will be low. And those usually, unless you think the patient coming, let's say, to the ICU with pneumonia, there is no reason to order TSH. But if the patient coming with severe shock and hypotension, you might need to do the cortisol, you will do the TSH, T4, because it's just acutely. But if the patient has been in the ICU for 4 weeks, if you see a question patient in the ICU for 4 weeks, usually this is like a prolonged time and patient is being sick. So there will be the thyroid hormones, all the 3 TSH, T4 and T3 will be low. It's a protective thing. T4 test, when do we order T total or free? As we said, we prefer the free T4 most of the time. And T3 also. T3, we order it in when we're suspecting hyperthyroidism. We check the free T4. And free T4 is, if you check it in other, like hypothyroidism or others, usually the answer from the lab is undetectable or very difficult to find. So usually save it for patients with hyperthyroidism. Cases, always look for the age. You get a case in the exam or in real life. When you interpret those thyroid function tests, look at the age, look at the sex, pregnancy, are they taking levothyroxine or not, any other medications or supplement that can confound the results, non-thyroidal illness if the patient is in the ICU or in prolonged hospitalization state. Some medications that known to interfere with the thyroid function test, estrogen. And why estrogen? Estrogen increase thyroid binding globulins and albumin and all the proteins in the blood. So if the patient is pregnant, estrogen is high. If the patient is taking oral contraceptive pills, these are good points in the stem of the question. If you see these patients taking oral contraceptive, they want to tell you something. So try to avoid the total thyroid hormones check. Biotin is an over-the-counter supplement, sometimes also affect the thyroid function test. If the result doesn't make sense, and you're thinking of central or secondary hypothyroidism, but the patient clinically does not fit, then ask for the drug list, and you usually find patients taking some supplement for the hair or the skin that's contain biotin. These are a list of drugs for you to look at and give you different problems in the thyroid function test based on their interaction with the serum TBG or on how the T4 is binding to TBG. But the main two I'll read for you is dobutamine and steroids. Those lower the TSH and give you like a hypothyroidism due to the low TSH. When thyroid function test results don't make sense, always go to the basic, have systemic approach, recognize the potential cause, understand the basis of commonly used laboratory assays. Is it the ELISA? How do they do the free test? Somebody remember how they do the free test? Free test in the past, how they do it? They get the total thyroid, the total hormone, forget about thyroid, like for the workup for endocrine hormones. Back in the days, still some lab do the same thing because it's cheap. They calculate the total hormone in the blood, whether it's cortisol, whether it's thyroid, just the total, estrogen, testosterone, they get the total, and then they can easily measure the bound protein bound, and then they subtract the protein bound from the total, give you the free. So that's why it's very important to know that your lab, how they do the interpretation. So if you have a problem with reading the thyroid function test, sometimes because it's the way it was done, not because of the actual problem in the patient. Different patterns of thyroid function test. On the left side, as we said, you look at the TSH, normal, and you have normal free T4, normal T3, euthyroid. Number two, if we have high TSH, but we have low or normal or low T3, primary hypothyroidism, high TSH, but normal T4 and T3, subclinical hypothyroidism. Why subclinical?
Not showing symptoms.
Not showing symptoms
But
and not showing low T4 and T3. But the TSH, because it's third generation, is very sensitive, it's high. So this is subclinical. Subclinical is important in certain patient populations like pregnancy, patient symptomatic with normal T4 and T3, those patients we treat. But if the patient, the TSH is 6, patient asymptomatic, T4 is normal, patient has no weight problem, no symptoms, nothing, we can monitor. We don't have to treat. This is subclinical. Low TSH and high T4 and T3, that's hyperthyroidism, is all the differential diagnosis. But low TSH and you have normal and normal T4, T3, this is subclinical hyperthyroidism, right? Differential diagnosis of normal T4 and T3 but high TSH, subclinical hypothyroidism. Patient is not taking the levothyroxine appropriately, malabsorption of levothyroxine, patient taking drugs amiodarone, assay interference. This is a sick euthyroid, non-thyroidal illness, recovery phase, and TSH resistance. Give you normal free T4, free T3, and high TSH. Low T4, T3, high TSH, this straightforward Hashimoto or atrophic thyroid, post-radioiodine therapy, post-thyroidectomy, will have low T4, T3. Hypothyroid phase of thyroiditis, some drugs, lithium, iodine deficiency or excess, neck irradiation, thyroiditis, thyroid infiltration by tumor or amyloid, congenital hypothyroidism. This slide here summarized to you a lot of exam questions, not now, but even in the future. These case presentations will come to you, like they're not going to tell you a patient took amiodarone. They give you a stem of question, patient was using, she has arrhythmias and she went to the cardiologist, she gave her a medicine, and later on the patient developed this kind of liver thyroid function test. And you have to interpret this. Patient will come to you with breast cancer and or lymphoma, and she get radiation to the chest and then they'll give you thyroid function test. So these are the ways to find out, like in the exam. Cases will present in this order, but the thyroid function test will be given, and or actually they might not be giving you in the standard thyroid function test, could be in the answer. They might ask you what's most likely thyroid function test look like and give you different TSH going up, 3 to 4 going down, B, TSH going down, 3 to 4 going up. So you have to know those tricks. If you see normal 3 T4, 3 T3, and low TSH, that's, as we said, subclinical hyperthyroidism, or recent treatment of hyperthyroidism, or some patients, as I said, taking steroids or dopamine, because it lower the TSH centrally, and the T4 and T3 can be low. Assay interference is always available and in these combinations. And non-thyroidal illness. High T4, T3, low TSH, that's a grave disease, toxic multinodular goiter, toxic adenoma, thyroiditis, some drugs like amidorol. You see, amidorol can give you different, give you hypo, give you hyper. Excess thyroxine ingestion, pregnancy-related congenital hyperthyroidism. Low free T4, low free T3, low to normal TSH, non-thyroidal illness, central hypothyroidism, isolated TSH deficiency, assay interference. High free T4, high T3, high TSH comes to you what TSH normal. Like if everything is high, could be a tumor in the pituitary producing high TSH, and that pituitary TSH going to the thyroid, giving you high T4, T3. You think this way, right? Very rare. All out of all the pituitary tumors, TSH normal is like less than 1%. It's like very difficult or very rare to find. So usually it's the wrong answer, unless it's just for exam's sake, they bring it, but in real life, you don't see this. Most of the pituitary adenomas are non-functioning. Most of them, pituitary adenomas, are non-functioning, not producing anything. And if they're producing, they're prolactinomas, followed by growth hormone, followed or ACTH, or Cushing syndrome, or Cushing disease. But producing TSH, way down on the list. Okay. So most of the time, this is assay interference. Look for the biotin, look for steroids, look for estrogen. Levothyroxine replacement therapy can give you this, especially if you draw the blood right away. Like if patient have hypothyroidism, high TSH, but she ingested too much thyroid hormones the day or 2 days before the, drawing the test. The T4, T3 can be high just because she just took it. But the TSH give you information about the last 3 weeks and will be high. Thyroid antibodies. In Graves' disease, we look for the TSH receptor antibodies, 70 to 80%, the way on the left or on the right. For Hashimoto's, anti-TPO. So if you want to memorize anything, don't memorize anything, please. Because TSH receptor antibody, from the name itself, TSH receptor, it's what? It's stimulating the receptor, opening, turning on the key of the thyroid to make too much thyroid hormone. So this is Graves', this is hyperthyroidism. TPO, thyroid peroxidase antibody. And thyroid peroxidase, we know that that's what combined what? The tyrosine with iodine, right? So if you block that, give you hypothyroidism. So when you see TPO, is hypo. When you see TSI or TS receptor antibody, this is Graves' disease. So if you want to order, pick one, just look. If your case is going through hyperthyroidism and you need an antibody, this is TS receptor antibody, thyroid stimulating hormone. And you can see the antithyroid globulin, they can be found in both. In Graves' disease, you can see that anti-TPO antibody also. Radioactive iodine uptake, we talked about that briefly. This is done like its uptake is an X-ray, it's not a blood test. So it gives you like a result, whether it's normal uptake or high uptake, but we're not looking for low uptake. If hypothyroid is suspected, we don't do this. We do this only for hyperthyroid. Normal uptake is 5 to 30%. You know how to do this test? We said you come the same day, You do the test, you get the radioactive iodine pill. After 4 hours, they do the uptake. After 24 hours, they repeat it. They see the washout. And if the thyroid is hungry, is very active, it will take this radioactive iodine in high amounts, and the uptake will be more than 30%, be 50% in grave disease sometimes. And it can be lower than that if the patient has thyroiditis. And why thyroiditis will have low uptake?
The cells are damaged.
Somebody in the back, why thyroiditis give you low uptake? Because the cells walls are damaged, they cannot trap the radioactive iodine. They open. So no matter what numbers of radioactive iodine you give to the patient still is not holding on to them because the thyroiditis, inflammation of the walls. But in grave disease, the walls are intact, but the receptors are turning on automatically, okay, by the antibodies, and it's just continuously making thyroid hormones. So they need this radioactive iodine. That's why the uptake is high. This gives you an example of how it looks like. This is not a percentage, this is a shape. So the thyroid uptake can give you a percentage of the uptake and give you the shape of the uptake. Based on the shape of this uptake, you see that the left upper corner, you see the cold nodule. Why we call it cold nodule? Because it's lighter compared to the dark background. Dark background means radioactive iodine uptake was high. And this gives you cold nodule. Why we care about cold nodule? Malignancy. Hot nodule means it's active. It's taking what it's supposed to do, taking the iodine. So it's active. Cancer is not active. So if I have a patient with low TSH, high T4, T3, and multiple thyroid nodule, I have to do thyroid uptake before I do any biopsy. Because I want to make sure the thyroid nodule is cold or hot. If it's hot, I leave it alone. If it's cold, I biopsy. Clear? And we repeat that also in the third lecture. In grave disease, you see the uniform darkness of the thyroid, and that's grave disease. Toxic multinodular on the right corner. You see the areas of like different patches, concentration. And the hot nodule, you see it's dark and the rest is light because all the radioactive iodine went to the most active area in the thyroid, which is the hot nodule. Autonomous nodule sees the suppression of the remainder gland. And thyroiditis, no uptake. So you can see that percentage-wise, low uptake. In the picture also, you see that even you cannot tell the boundaries of the thyroid because the walls are damaged. It's not holding on to the thyroid hormones or radioactive iodine. Based on the thyroid uptake, the differential diagnosis, whether it's high uptake and low uptake. So if I see a high uptake, the differential diagnosis usually what is grave disease, toxic adenoma, toxic multinodular goiter, tetrachoma, HCG-mediated hyperthyroidism. And this by the uptake, by the percentage differential diagnosis. But by the picture, when I look at them, I can tell the difference between grave disease and toxic adenoma and multinodular goiter. Just like what I showed you here. This is, you can easily, there is hyperthyroidism, but based on how it looks, I can differentiate the high uptake. If I see low uptake, thyroiditis number 1, exogenous thyroxine, excessive replacement, factitious, stroma ovary, follicular thyroid cancer. This non-thyroidal illness we talked about, reverse, and this is how it looks like in the first, depends how sick is the patient. You can see that the 3 lines, T4, T3, and TSH all can become down with prolonged hospitalization and the patient getting sicker. And the reverse T3 you see way up in the top. We have a few minutes for the 3 cases, okay? Case number 1, who can read? Okay.
A 45-year-old lady presents to your clinic complaining of palpitation, tremors, sweating, and weight loss of 5 kilograms over past 2 months. Exam showed tremors, tear blood, leg contraction, moderate goiter, and pulse is 96 per minute. What do you suspect? Hyperthyroidism.
Hyperthyroidism, why?
Because of the palpitations, sweating, the weight loss, the goiter.
So clinically,
Yeah.
so this is another thing I wanted you to know those two terms, clinically, biochemically. So you make your diagnosis by the history, an exam give you what? Clinically, the patient grades. Biochemically, it has to be the same line. So usually, even in my assessment, when I write for my, like I see a patient, I say clinically, hyperthyroid, biochemically, euthyroid, biochemically, hyperthyroid. If clinically and biochemically hyperthyroid, then the diagnosis is hyperthyroidism. Then I have to decide which one. Sometimes doesn't fit. So patients come to you always complain of a lot of things. You suspect clinically, but you have to confirm by biochemically, by labs. So what do you suspect? Hyperthyroidism. But what's the next step? What lab?
Yes. Antibody, iodine antibody.
Pick one. TSH or 3T4 or antibodies or thyroid uptake. TSH. Because the TSH gives you a lot of information. It was undetectable. Undetectable TSH. Then you go for T4 and T3, right? That because now you confirm biochemically this patient most likely is hyperthyroid. But some people might think because TSH is low, this could be central, but this is very rare, right? And usually it's detected, even if it's central or secondary, usually TSH is detectable. When you see it undetectable like this, most of the time this is because of too much thyroid hormones. You check the T3, T4, came back 39, that's high. With diagnosis, hyperthyroidism. What's the cause? How would you confirm your diagnosis? Now we do the lab. We do the TRAP, thyroid uptake and scan, and thyroid ultrasound, right? Okay, 1 minute. Okay. Okay, case 2, 25-year-old woman with significant past medical history presented to your office with fatigue, weight gain, cold intolerance, hair loss, family history of thyroid disorder, exam showed a goiter. You suspect hypothyroidism. What test you would do?
Yes.
What test for hypothyroidism? Again, TSH, right? TSH came back 14. Next step, you check 3T4, came back 9. Any other supporting test do you need? I don't need it, but I can do anti-TPO antibodies, right? This is another patient. She's going for pregnancy. TSH was high. We repeat it was still high. 3T4 was 14. What's your diagnosis? Subclinical hypothyroidism. And we said if you have subclinical hypothyroidism in pregnant lady, what you should do? Treat or not treat? We treat, right? Correct. Why we treat? Yes, because the baby doesn't have thyroid gland for how long? For 3 months. After that, the baby can make thyroid hormone. But the first 3 months, if the patient is hypothyroid, we give her levothyroxine. If she was already in levothyroxine, what we do? We increase the dose until the TSH in the trimester become what? TSH in the trimester. The goal is less than 2.5. The second and third trimester less than 3. Okay. Good. See you early tomorrow morning.
Thank you, doctor.